Okay, so with the understanding of the potential genetic etiology and the diagnostic scheme, we now are going to shift gear to look at patient management. From a pediatric dentist's perspective, I will be talking to you about patient management with management of patients with congenital tooth defects, focusing primarily from the primary to young permanent dentition. I'm hoping that through this presentation, you'll be able to get information to recognize the special challenges presented by this group of patients and be able to understand stage-appropriate objective when devising treatment plan and become familiar with treatment options for this unique group of patients. In case you're practicing in the state of Michigan and you have a patient with inherited dental defect who's age 21 or younger, and the family cannot afford the treatment, as a dentist, you will be able to contact Michigan State Department of Community Health and complete a Children's Special Health Care Service medical eligibility report form on behalf of your patient. By providing the specific diagnosis and the comprehensive treatment plan with correct procedure codes, the state will evaluate the request and determine the patient's eligibility based on family income. Many of these patients referred to School of Dentistry were able to receive comprehensive treatment because of this particular service provided by the state of Michigan. This was a patient of mine during the first year of pediatric dental residency. I saw her at the Children's Hospital at Los Angeles. She was 12. She was very pretty, but very shy. She was apparently embarrassed by the appearance of her teeth. And unfortunately, I did not know what the condition was. The attending decided that the treatment that she needs is way too complex, and a prosthodontist probably can better serve her. So she was sent away. I didn't know whether she ever continued to pursue to seek dental treatment, but I hope for many years that I will be able to see her again one day and tell her that her condition is hypoplastic aminogenesis imperfecta. And yes, treatment from simple restoration to full coverage reconstruction are possible that will restore her dentition and give her excellent smile just like the average people. In addition, with 5 cc of peripheral blood, we will be able to run a genetic test in the laboratory and identify the potential genetic mutation that's responsible for the condition. So she will be able to know how likely would her child have the same condition again. So, the questions that your patients with congenital dental defects would want to know from you are, what is the diagnosis? Can these teeth be treated? How likely will my child need to go through life with the same condition? So with that in mind, let's review how these patients were treated. In the early days, a long time ago, majority of these patients, their teeth remained untreated until early 20s. Then these teeth will be extracted and patient will went through their life either toothless or wearing dentures. Around 1970s, the consensus was definitive management of the dentition should not occur until full dental and gingival maturity, that is adulthood. However, the dentist should manage the child's dental care to help maintain the dentition until the time of definitive treatment. And today, the consensus has been developed. The standard of care for this group of population is likely to contain many of these 6 steps. First, the risk should be identified, followed by early diagnosis. The dentist should consider reimmunization and desensitization measures for these patients. Prevention of caries and also prevention of post-eruption structural defect should take place. And then the definitive treatment involving extraction, restoration, and long-term maintenance will be ideal. The long-term goal is to have a well-adjusted dental patient who has a pain-free aesthetic dentition in adulthood. So we're going to focus on primary to young permanent dentition in this presentation. We're going to look at what are the common problems, what are the special considerations, and treatment options. This group of patients, be it enamel or dentin defects, they're likely to present to you with very poor aesthetics. Their teeth can be very sensitive, so much so that it's very hard for them to brush their teeth. I have a 5-year-old patient with amelogenesis imperfecta who told me that she has never enjoyed ice cream or popsicles because when she takes a bite, her teeth would hurt like crazy. There's an increased periodontal problems, compromised chewing functions, altered occlusal vertical dimension, and significant structural loss all contribute to a lack of sound prognosis for these patients. In addition to these clinical problems, they are very real, well demonstrated in the literature, psychosocial issues associated with these patients. They typically have avoidance behavior, constantly feeling distress, discomfort, and disabled. They are afraid of negative evaluation on them coming from their supervisors, their peers, or teachers at school. They feel that they are not able to master skills or knowledge, and they have much lower self-esteem. Overall, their self-perceived quality of life is much decreased. So with these in mind, as care provider, we need to be understanding and supportive, so hopefully we can develop a good relationship with them and encourage these patients to follow through sometimes a very long and tedious treatment process. So now let's look at some of the specific characteristics that this group of patients presents to us. In terms of growth and development, very interestingly, among the population of AI patients, they seem to have accelerated tooth eruption on average by 1 year of age. And 42% of the AI patients will present with skeletal and or dental open bite, compared to only 12% of their unaffected family members. So these conditions definitely would need to be addressed in conjunction with orthodontic management prior to the definitive restorations. Also associated with hypoplastic AI patient, there's a 6-fold increase in tendency of these patients to show impaction of their teeth, and also anomalies such as follicular cysts and gingival fibromatosis. It is critical when you see a patient like this, call on your oral surgeons and discuss about treatment plan in various phases for this patient. Treatment need to be, the decision on treatment plan need to be made early so that there's no significant resorption of the bone, and therefore that jawbone fracture during the surgical extraction of these teeth would not be a potential complication. Many of these patients, AI with gingival fibromatosis or enamel renal syndromes, have severe impaction as well as cystic change and coronal resorption of the dental crown. In addition, there are pulpal stones associated with these teeth. Patient with severe dysplastic dentin, they typically experience very early pulp exposure, multiple abscess. It could be extremely painful and difficult for these children. Patient with dentin dysplasia type 1. This condition is also known as rootless teeth. They have pulp chambers and root canals obliterated very early on, presenting very special challenge for endodontist. Type 2 dentinogenesis imperfecta, typically they have bulbous crowns, very thin and short roots with canal obliteration. Even following full coverage restoration, a lot of these teeth will fracture at gum line, presenting very difficult challenges for the dental care providers. As Dr. Zimmer mentioned, many of the patients with dentinogenesis imperfecta tend to have class 3 tendency, and they would require orthodontic management. Their crown fracture and enamel damage is quite common. Again, a patient with bulbous crown, canal obliterations. These bulbous crown actually would cause ectopic eruption that sometimes complicate the hygiene practice and cause severe dental decay. Again, another case with dentinogenesis imperfecta with bulbous crown, ectopic eruption, and early attrition of the dentition. And therefore, it is important to crown these first permanent molars early on in order to maintain the vertical dimensions. For patients with extremely worn dentitions, it is important that you consult the periodontist to consider various approaches to lengthen these crowns and augment the ridges. So with all the special characteristics of these patients in mind, let's look at what are the treatment options. During the primary dentition, the treatment objective should be established to ensure favorable condition for eruption of permanent teeth, and as well as the normal growth of the facial bone. So ensure the proper development of craniofacial complex of your patient. It is important to maintain the dental health and consider aesthetic dentistry when indicated. Ensure adequate function and establish good rapport so that your patient will continue to come back and follow through with the treatment recommendations. Specifically in the anterior region, when restoration is needed, the different materials such as glass ionomer and composite can be considered. In the stress-bearing area, you probably want to consider composite. In a high caries risk patient, you may consider glass ionomer. Composite also provides much more superior surface finishing. And when the teeth are extremely worn, needed to be extracted, pediatric partial denture can be considered. Unfortunately, most of these patients, because of their age, the extent of treatment needs, as well as the extreme sensitivities, so that you can imagine approaching a quadrant at a time, and by anesthetizing only one quadrant is not going to be adequate. And a lot of these patients would need to be treated in the operating room setting. For pediatric dental patients, stainless steel crowns or stainless steel crowns with facings or pedo jacket crowns are materials of choices. During the mixed dentition stage, the first permanent molars should be properly treated early on to ensure to preserve the structure and maintain the vertical dimensions. Anterior restorations is going to help restore the aesthetic as well as function, and is extremely critical for growing child. It is important to consider that the pulp dimension of these teeth are extremely large, so you need to balance the amount of reduction and also the space created to accommodate the bulk of your restorative material. Balancing occlusion is definitely a key. In terms of anterior crowns, during the mixed dentitions, direct composite or indirect resin veneers can be considered. Definitely, orthodontist plays an important role in the management of these patients. As mentioned, AI patients tend to have anterior open bites, and DGI patients tend to have class 3 malocclusion. In addition, there are severe overbite, overjet, as well as very poor arch forms. Those all need to be improved prior to definitive restoration. And orthodontic bracketing is definitely not a contraindication for these patients, except we got to keep in mind at the time of debracketing, there's a high risk of enamel fracture. You got to inform the patients and families beforehand. During the young permanent dentitions, endodontic treatment may become necessary for some conditions such as dentinogenesis imperfecta, where the dentition is extremely worn, then endodontic treatment may become a necessity. For the AI patient, the endo procedure does not differ. However, for DI and dentin dysplasia patients, it's continued to be a very challenging situation. This is a patient with aminogenesis imperfecta. Anterior teeth were traumatized, needed endodontic treatment. Because of discoloration prior to the veneer placement, these teeth would need to go through bleaching. And for those cases with extremely short clinical crowns, your collaboration with the periodontist would be extremely critical. Crown lengthening procedure plus ridge augmentation might be necessary. For patients with extremely short and extremely worn dentitions, overdenture may be considered just so that the arch dimension and the ridge integrity can be preserved. The key is continuous monitoring in order to ensure the integrity of the restoration as well as the periodontal structure. When it gets into the permanent dentition, the definitive prosthetic treatment is aiming at restoring the vertical dimension and the functional capacity of the patient. So with that, I hope that you are convinced that it is no longer reasonable to expect your patients with these inherited dental defects to settle for denture as a cure. Quality care can be provided, and long-term optimal prognosis can be ensured as long as treatment is properly planned and delivered. Just to give you an idea how much it will cost in order to provide the optimal care for these patients. This is based on a study published in 2009, which is about 4 years ago now, from Europe, Switzerland, so a country with a very different health insurance system from ours. The study compared patients with amylogenesis imperfecta, dentinogenesis imperfecta, and patients with clefting, as well as hypodontia and oligodontia. On average, the patients with AI DGI received about 24 teeth per person of treatment. And the total treatment cost was about $20,000 at that time. Compared to the other group of patients, the patients with AI and DGI acquired the highest treatment cost, and they needed the most frequent maintenance and retreatment. Because of the condition being inherited condition, it's definitely going to affect the primary as well as the permanent dentition, although the degree of severity may vary. The primary goal of the treatment should be to address each concern as it presents. However, the dentist needs to have an overall comprehensive treatment plan in mind that outlines the anticipated future needs and present that properly so the family can be well prepared. The goal of any early intervention is to retain the teeth for as long as possible and allow the patient to grow to the developmental capacity. The optimal care should include to preserve structure, optimize aesthetic, and prevent caries and periodontal condition to further complicate the patient's dental health. In summary, I hope that because of today's program, you'll be willing to take on this group of patients and either provide care or guide them properly to seek care. It is important that we, researchers and clinicians together, taking care of this group of populations, that we will work together to influence the decision on healthcare insurance and ensure in the future that our dental patients can receive proper insurance policy coverage so that when genetic diagnosis for them is necessary, that can be possible. And comprehensive care for restoring their smile will become a reality, because we know that it's well established in the literature that a healthy dental smile is critical in improving the patient's quality of life. So thank you very much for your attention.